It is a huge, huge honor for me to be interviewing my buddy Justin Moody, who you came by the office last week I saw you?
Yes, sir.
Yeah, and you were out for teaching implants. And I wanted to get you on so bad because you're a real world guy placing lots of implants, and you're not you're not doing it in Beverly Hills or Key Biscayne, Florida, or Manhattan. You're out there doing it in South Dakota. And I always hear dentists here always whining. Everybody's got an excuse. No one's got, they don't have the right attitude. They always got an excuse. They're like, well, you don't understand. I'm in Salina, Kansas. And it's like, dude, I know Justin Moody. How many implants have you placed in South Dakota?
Quite a few. Quite a few.
Do you have any ballpark number? It's more than 100.
Yes, sir. Yes, sir. It's a few more than 100. A couple zeros, probably.
10,000?
Maybe in my career, I'm getting pretty close. Somewhere.
Yeah. So what do you? So here, I want to start. There's so many things we could talk about. In fact, we should probably just talk all day. So many people go into dental school, and then when they come out, they decide that they don't like blood and they don't like surgery. If you didn't like blood and surgery, wouldn't you have been an engineer or a scientist or a physics major? I believe they really liked blood and guts in the human body and wanted to fix the human body. But now that they're scared, they just say, well, I don't like surgery. I don't like blood and guts. How come guys like me and you just can't lay a flap big enough and other people just don't want blood? Do you think it's just fear?
Yeah, some of it might be fear. Some of it might be just, I think some of it comes down to the fear of, hurting our patients or our patients having, pain afterwards. And, for me, I hear you on your podcast talk all the time about, a root canal doesn't hurt. Matter of fact, a root canal is what makes your tooth feel better, and, the implant itself, proper treatment planning and pharmaceutical protocols. Most people say that it's one of the easiest things they've ever had done. But I think the real misconception comes in the dental schools, because we're really taught that the only people qualified to do this, are specialists and those that are, have a few more years of education than we do. And I think that fear, ends up translating outside of the real world.
Yeah, I always want to ask every orthodontist, did you ever do your first case, or did you already have 100 finished cases under your belt at birth? Everybody has to start somewhere. But my big beef with the education, that line of thinking, is where you and I are from, and that's I'm from Kansas, you're from South Dakota, and that is, half of Americans live in 117 big city metros, and the other half live in 19,022 small rural towns. And these dental schools don't recognize that these small town Americans, they don't have the 9 specialties recognized by the American Dental Association, yet their tax dollars are paying for these universities. And when these kids walk out of school and say, well, I'm $250,000 of student loans, I don't care. The people of your state picked up 3/4 of the cost of your education. So when you when you tell someone at University of Missouri, Kansas City, well, if you want to be be an orthodontist, then you send them back to a town of 3,000 that doesn't have an orthodontist. This doesn't add up.
Well, it doesn't, Howard. And I think where the schools, having gone to University of Nebraska for undergraduate and then Nebraska or Oklahoma for dental school, those land grant colleges, I think their purpose is to send people back into the communities that are paying the bill to help those communities. I have 3 general dentistry offices down in Western Nebraska, and the closest one of them to an oral surgeon is 120 miles. Endodontist, same way, 120 miles. Periodontist, 120 miles, one way. So when you make a referral to one of these specialists, and if they only want to do a consultation, this poor patient has taken an entire day off of work to go have a consultation, and then an entire day off, of work to have the procedure done. So, my biggest thing with the young doctors that I have working in my system is the one thing that's missing in dental schools and in dentistry altogether is, mentorship. Trying to get these, that confidence level back up, and because our patients want us to do it.
Absolutely. So Justin, what percent of the general dentists? There's 120,000 general dentists in the United States, 30,000 specialists. Of those 120,000 general dentists, how many of them do you think are virgin agnostics, have never placed a single implant surgically?
Well, I don't think more than about 5% are placing. So I suppose 95% of them don't have, you know, don't have any surgical experience in placing an implant.
Okay, well, I just like to get things done. I like to get them implemented. I like to look for the tricks between guys like you and me who did well versus the ones that I watched for 28 years that didn't do well. And this podcast is a big part of that because in my walnut brain, what I saw is all the guys who signed up for the AGD and got their FAGD exam, which was 5 years of dentistry, 500 hours of continuing ed. They just leaped ahead. And I saw that the dentists who took 100+ hours of CE a year, they just skyrocketed to the top because they just got their head filled with a lot of good information. That's why I'm doing these podcasts, because what I'm doing is I'm tricking these kids. They say they don't have the time or the money for CE, but they'll download it for free on iTunes and play it in their car to work. So what I'm doing is I'm getting legends like you, and this young girl's driving to work, and she doesn't want to even go to the monthly study club, once a month. So I want you to start with, we got to go from the first step to the second stairway. I mean, we got to walk up, 10 stairs. What would be, you're talking to about 7,000 dentists right now. I bet 6,500 have never placed an implant. What would be step one, Justin? I've never placed an implant, and someday within a year, I'm going to place an implant. What would you tell her to do first?
Everybody wants to talk about, go taking a course. And there's a big difference between taking, we used to call them weekend warrior courses. They were put on by an implant manufacturer. Their job was to get you excited and get you rah-rahed and go out and place an implant, and buy their kit. Buy their motor, buy their starter kit, go out and start placing some implants. And then when you want some more information, some more education, they'll, we'll send it to, we'll send you someplace, and there's a ton of these courses out there, and truthfully, there's a few of them that are taught by some really good guys. But at the end of the day, implant success and really implementing into your practice, it's so much more than a weekend warrior course. It's so much more than a Thursday, Friday, Saturday. Even if you got 3 days, I went through Misch. I went through the AAID Maxi course. I've gone to Picos and Russo and all those people. And my skill level and my teaching philosophy, I didn't make this stuff up. Mine's a culmination of all the things that I've learned of what works well in my hands from one guy to the other. But what I do know is that the success I've had in training doctors and doing it the right way, with getting them on board with implant rationale, risk factors. I'm a COIS Center mentor. I'm big into assessing the risks and trying to. I want docs to finish strong. Have a high success rate for those first 100 they place, and that comes with having a good solid foundation.
Now, John Coyce is 100% Greek. On Christmas, do you send him a bottle of Windex? Does he spray the implant with Windex before he cements the final restoration? That's
possible.
That's a joke to the movie My Big Fat Greek Wedding. So
Yep.
so when a guy like you is so obsessed with implants, do you do anything else other than implants? I mean, do you still do a molar root canal? Do you do fillings, crowns? What do you actually do?
Well, I try not to.
Because you got 3 offices right now. So
well,
right.
I have 3 general dentistry offices that have associates in them, and then I practice in an implant-only facility in Rapid City, South Dakota. So I have a very unique niche here in South Dakota, as I see work from about 72 different dentists in 4 states. So
That refer to you?
Yes, sir. So even though I'm a general dentist, I have every credential on the planet, and at the end of the day, that doesn't make me, any better than the next guy. All it does is gives me, the knowledge base. What I try to do is I try to make implants easy and predictable and successful for these docs, because most of them want want crown and bridge. They don't want to mess with torque wrenches and access holes and excess cement and complications. So over the last 9 years being in Rapid City, South Dakota, I've carved out a referral-based niche of giving my referring doctors exactly what I want, what they want.
Okay, give my listening dentists, give my homies exact verbiage. I'm a patient, and I just say to you, well, Dr. Moody, what lasts longer, the 3-unit bridge or the implant and crown? Because it looks like they're about the same price.
Well, they are about the same price. However, the bridge is going to force me to grind down your adjacent tooth and irreparably harm them, and causing them to be more susceptible to caries, more susceptible to future endodontic treatment. The numbers are, the literature is very specific on that. Or we could just replace the missing tooth with a dental implant. The dental implant is nothing more than a man-made root designed to replace the root of the missing tooth, or the tooth that needs to come out. And then after a short healing period, you will have what you actually want, and that is the crown, the piece that makes it look like a tooth. It's about the same price as a bridge. It will prolong the life of the adjacent teeth, and you'll be able to floss around it and clean it.
Okay, well, I drove 100 miles to get here. Can you pull the tooth and put in the new root, the man-made root, at the same time, or do I have to come back?
Do you have enough time to get numb?
Yeah.
Then we're ready to go.
And you'll pull the tooth and put in the replace it with the missing the man-made root at the same time?
Immediate implants are 42.5% of my business. I do have some criteria. That the success rate, that's a kind of a misnomer that people think that immediate implants are less successful. If you operate in a risk factor controlled zone, they're just as successful as healed sites. Now, what I don't do is I don't place implants into what I call a hostile site. Something that's got purulence to it, some sort of large soft tissue defect. We need to do, may need to do some augmentation procedures first. But the majority of the teeth that I see, Howard, are broken endodontic teeth. Endodontically teeth that need to be retreated. Coming out of the oil fields in North Dakota, I see a tremendous amount of drug-induced caries, meth mouths.
Meth grinding. Meth mouth for caries, but I see fractured bicuspids just from grinding their teeth.
Oh, absolutely, because they're
Is that still booming there? This is October of 2015. Is fracking still booming, or is that busting?
They would certainly like the price of oil to be a little bit higher than it is today.
But are they laying off people, or is it flat?
Yeah, there's layoffs happening up in the Bakken oil field for sure.
Okay, I don't know how old you are. I assume we're the same age. I'm 53. How old are you?
I'm 44.
Oh my God, you're a decade younger. A decade younger. I think you are my age just because of all your experience. I mean, you've come a long way to be 44. Unbelievable. But I want you to sell these young kids on a mindset. These, half of America's rural, and I really believe those dentists are sold all day long by their patients that they're poor. And I've lived in the big city, Phoenix. I've lived in small town Kansas, and if you see someone driving a Lexus in Scottsdale, it's leased. If you see anybody at the BMW, it's leased. You go find someone driving a truck in Kansas, they probably paid cash for it. And the dentists always believe that these rural people don't have any money, and I think it's exactly the opposite. They don't have all these shops and eating out and all these things like that. They just don't spend their money. How are you selling big cases in Western or South Dakota and Nebraska? Do they have money? Are you financing it? Do you think you're a better salesman, or do you just refuse to be sold when Grandma says, "Well, I don't have any money. I'm on a fixed income," and you in your head, yeah, and you haven't spent a dime in 10 years. You have more money in your savings account than probably anybody who just graduated from law school 5 years ago.
Those are there's a multiple questions in there, and I'm going to address the first one. I think if you were to ask any one of my associates if they would give up practicing in where they're at and go back to Lincoln or Omaha or even down to the Front Range, in Fort Collins, Denver, the answer would be no. My associates have been with me. We have three young doctors. Two Nebraska grads and one UNLV grad. Um, Moving out to Western Nebraska has been the best thing that they ever did, and they'll tell you. And for a number of reasons. We spend zero amount of money every year on advertising. Our demographics in Western Nebraska, but it doesn't matter if it's Western Nebraska, Western Kansas, Western South Dakota. The demographics work because people are used to driving. And people, the dentists, there's not that many dentists out here. So our like I said, our numbers are really, really good. So what you may make up in lower wages, we don't have to charge a tremendous amount of money for a lot of our dentistry. And truthfully, our overheads are low because the buildings are cheaper, the cost of living is cheaper, and our dentistry is cheaper. But you know what? Cheap doesn't mean that the perception, is that you got to go to a city to get the kind of high-end care that you would need other than you could get in Western Nebraska. But my little town of 1,100 people, Crawford, Nebraska, where I grew up, I was a fifth generation to grow up on the ranch out there. I mean, nobody's ever owned that property except it went from the Louisiana Purchase to the Moody family in 1883.
Are you serious?
Yeah.
Oh my God, that is hilarious.
My dad,
Wow.
My dad and my brother still, work. It's a working cattle and wheat ranch, and it has been for five generations.
And they bought
And
that from France, Louisiana Purchase from France.
yep,
What do you
yep.
think was the worst real estate deal? Russia selling us Alaska for 11 cents a square acre, or France selling us the Louisiana Purchase?
It's kind of a toss up because you got one where you got all the natural resources in it, and the other one you got the breadbasket of the world. So I don't know.
And when anybody says they're not you can't make any money in real estate, I'm like, how can you say that and live in America? I mean,
100%.
oh my
You
God.
know, Crawford, Nebraska had 1,100 people. Like I said, I was a fourth generation to grow up to graduate in that high school, and I built a 10,000 square foot, 10 operatory office. It's been on the front of the Sidekick magazine. We had the first cone beam CT machine in the state of Nebraska in 2006.
That was an ICAT, right?
Yeah, and when I put that in, I guarantee you the other 850 dentists in the state of Nebraska thought that there was one bat crazy dude out in Western Nebraska, and now we have them in every office. We have CAD cam, we have intraoral cameras, digital X-ray. That technology. There's nothing in the city that we don't have, but yet we get to offer it, and we get to offer to our patients. But to answer your last question, how do we do that kind of dentistry? Our patients are exactly what you said. That rancher that drives up in his truck. Somebody may talk about buying a $50,000 Lexus, but that rancher may be driving a $70,000 diesel pickup that he uses to haul his horse trailer. And he didn't buy that thing until it was, until he could pay for that. And if you prejudge, and I think that's the worst thing we do as dentists in the entire planet, is we prejudge every patient that walks in our door. Whether, by the way they look, or, by the way they dressed, or by the car they drove. But the fact is, out in Western Nebraska, when they walk in, if you don't have something that they find a worth in, if you can't show them the value in what you're selling them, then it doesn't matter, because it's not about the price. It's about, is it valuable enough to them to make that purchase? And I think when you have good, solid implant education, and you can talk to them about the real benefits of bone maintenance and longevity and maintaining your facial features and being able to eat. When you tell somebody that I'll take your teeth out and put a set of dentures in, but you eating that steak that you worked so hard to raise for all these years is a thing of the past unless you like the blender. You just turned the corner on that person. So, to the young dentists out there, I'll tell you what, if you pass up looking at some of these rural opportunities, I think you're crazy.
Some of these famous Hollywood movie stars in real life are painfully shy introverts. Do you think a lot of these dentists listen to you that just they just they're just shy. They're mathematicians and engineers at heart, and to try to sell you that you need, a big implant case is just frightening. Do you think they can learn that in your program? I mean, is yours more a technical program, or do you help them with the skills of being an actor and just saying, "Come on, you're on stage, you're an actor now." Show some enthusiasm and convince grandma that there's no way to spend a life with a slipping, sliding, miserable denture if she can snap that thing down and eat corn on the cob.
I think that's one of the things that I do differently than what's out there today, and that is, every implant course has its didactics. Whether you're sitting there and looking at slides and reading through the manual and finding the numbers and things like that, but what I incorporate into that is a practical side of, how do you how do you talk to the patient? And I tell you what, Howard, I wish that I'm going to write a book about the associates that I've had over the years. Even at 44, I've had a number of associates. I'm fairly motivated to try to bring bring dentistry out to these smaller communities. My offices sit in towns of 910 people, 1,110 people, and just shy of 10,000 people. And these guys, I guarantee if you asked them, they're making twice as much as any associate that went to work in the cities. And it's it's really about getting them to talk to the patient. And I don't know how many times I've walked by a room, and the associates in there, and they still got their loops on with their 4-inch 1,000-time magnifiers in, their mask is on, and they're sitting kind of next to the patient and they're talking in their ear hole. And the patient, they can't understand what they're saying, and they're talking to the patient about irreversible pulpitis, which, hell, I don't even know what the hell that is. What I try to teach them is like, hey, listen, our patients are human, and you need to be too. Get that stuff off your face. Get the loops off, get your mask off.
I know.
Wheel your
I know.
wheel your chair down to the foot of their chair and look them in the damn eye, and just say, hey, Mrs. Jones, this implant's expensive. I don't care if you're a dentist or a school teacher or a housewife. It's expensive. However, to maintain the bone and be able to eat and chew and look the way you need to look, not now, but in 20 years, what I'm talking about is important to you. And I just tell them, is this something that you want to do? And when they say, almost all of them say yes, then it's your team's responsibility to figure out, how we're going to get it paid for and how we're going to schedule it, but, for me, that's part of, and it's a full 2-day course. Is a full 2 days of the courses is to, how to talk to people about these cases, how to get them energized, and it's also about building their team too. Because if
They don't even let them talk. They get in trouble when they talk. The hygienists tell me they get scolded that they were diagnosing and breaking the law, and you're not a doctor, and the assistants. I mean, it's crazy. And,
it's not
and, and, and when if I walked into 100 offices, 1% has that feeling like when you walk in your office or mine, where it's just approachable and fun, and everybody's talking, and it just it's a human, fun place. We all play in the sandbox. At least 80%, you just think you walked into Sister Mary Aloysius' library.
I agree. It my advice to these young doctors, if they want to get into implants, and the only way to get really good at implants is to do a bunch of them. And if you want to do a bunch of them, you've got to be able to sell it. But it's not just about you. You can go to every course, you can travel from corner to corner and listen to every dog and pony show and get all this knowledge that you can. But when you come back and you sit in the back and nobody ever comes through and nobody ever comes through, and then you don't realize that you got somebody at the front desk who may mean well, but somebody calls and says, hey, I just moved to the area, and I was told I need an implant. Does Dr. Farran do implants? And the lady says, oh yeah, he cut, he makes a big cut in your gums and uses a drill and puts this, screw in your jawbone. I'd be like, yeah, that doesn't sound real great. It's the little things about having every person in your team with the same message, the same man-made route, the same, gently placing it, the same giving you back your smile and your function and stopping the bone loss. If everybody talks about that, my hygienists are all bonused on implants that come out of hygiene. I mean, think about it. What part of your office is with the patient the most? The hygienist. And who has the most opportunity to either drop a patient education video in front of them while they're getting their teeth cleaned, or to talk to them about this ill-fitting denture, this ill-fitting partial, or this edentulous spot? I mean, that's the best place in the world to come up with work.
I've always said that I think 4 out of 5 dentists could double their income if they took a weekend job as a bartender or a waiter just to learn how to talk to people. You know what I mean?
Absolutely.
If they could just walk up to a table and just feel at ease. I mean, some have done it through Dale Carnegie courses, but if they could just learn how to talk to people and just feel comfortable, because I've always thought that these patients are going to spend all their money anyway. They're going to spend it all. In fact, America spends about 101% of its income every year. They just go deeper in debt. They buy everything. They buy their cars, their clothes, their vacations, their cruises. And when a patient walks in and they're pointing to one molar, and then you sit there and you start thinking, well, they don't have any money and they're just pointing to this one. I'm just going to fix this tooth. Versus the upper 10% of the dentists like you and me that can sit there and slow down, take full x-rays, a full exam, a full treatment plan, and motivate them. Like, wouldn't it just be nice to just get this all fixed up? I mean, you don't buy a car in parts and pieces and assemble it after 5 or 10 years. It's not like a third world country where their house, first they lay the floor, then you come back 5 years later and there's 2 walls and takes 5 years to get a roof on and it's never finished. You know what I mean? I mean, just go for it. I want to talk specifics about your course. How does one of my listeners learn from the man?
Just go to justinmoodydds.com. You'll see a list of courses underneath there. We're just
what is the curriculum? I mean, is the intro level 1, 2, 3, 4? Do you take them in order? How much do they cost? Where are they given at? Is it in Rapid City?
Yep. So we have 6 courses, I believe. They range from Implant 101, which is the edentulous mandible rationale for implants. Basically, 101 is designed for the doc that haven't taken a course yet. They're going to get some risk assessment. They're going to get some pharmacology updates. They're going to find out, how to place an implant in an abundant piece of bone and in the edentulous mandible. All cases that every practice has an abundance of. Go back Monday morning and do your first 50 cases on healthy individuals with abundant bone.
For denture. And you're saying dentures?
And lower edentulous mandibles in between the foramens, couple locators and a denture.
So that's interesting, Justin. So you think the entry level grade school first implant cases should really just be in mandibular lower removable, not a single tooth replacement for the most commonly missing tooth, which is
the lower molar. Yeah. So it could be either one of them. I think that is this a
2-day course or 3-day or?
It's a 2-day course, 18 hours worth.
Friday, Saturday, Sunday. What days?
Friday, Saturday.
In Rapid City.
They're held in Rapid City once a year. We usually generally do it somewhere across the country. We don't have that schedule out for 2016 yet, but
you should start doing that in Phoenix, and I'll be your marketing arm. We'll start. There's 3,800 dentists just in the Phoenix metro. Can you believe that?
That would be an awful good place for a South Dakota, Nebraska guy to go in February.
I know. You know what's funny is when this town literally prays that Nebraska makes the Fiesta Bowl out here, because whenever the teams are from the South, like Florida Seminoles or something from Dallas or California, the attendance is that great. But my God, when Nebraska makes the bowl, this entire city turns red for like 10 days. I mean,
Yeah,
they come 3 or 4 days before the game, stay 3 or 4 days. You can't get into a restaurant or a shop for a week if Nebraska plays down here. So Rapid City. So you fly straight into Rapid City, or is that, or do you fly
Yep.
into it? Really?
We have a direct flight from Mesa on Allegiant.
Okay.
We're served by Delta from Salt Lake, Minneapolis, and Atlanta. We're serviced by United direct from Denver, Houston, and Chicago, and to Dallas on American. So Rapid City is a, for some people it's a direct flight, but for everyone else in the country, really, it's a two flight stop.
So that's
And
a Friday, Saturday course, and how much is it?
2250.
2250. So their first damn case would be double that revenue.
Absolutely. Absolutely.
I mean, that's like when people don't want to take an Invisalign course or an orthodontics program. It's like, dude, if you go through these ortho courses and do one case, you get your money back. How can you not do one ortho case in exchange for the knowledge of how to do ortho, which will help you understand your TMJ and occlusion and everything else? So 2250. I mean, I don't. Every time I see an implant course, they're $5,000 to $10,000.
Um, I've taken those courses, and truthfully, it needs to be inexpensive. The only way I can get out there and teach people to do what I do, because I do love it. I'm a Monday morning guy. I mean, don't get me wrong, I love the weekends, but come Monday morning, man, I'm ready to get back after it because I like my job. And the only way for these docs to be able to, especially my younger docs, everybody targets you and me, because they feel like we've been in practice long enough that we got all this disposable income, and maybe our kids are grown enough to where we can fly and stuff. But we did the 201 course 2 weekends ago here in Rapid City, and we had 12 docs in there. 4 of them were brand new grads. And
Nice. Now that wasn't your 101 course. That was your 201 course.
yeah, that's because these 4 guys that took 201, they also took 101, and they also did it. They also did it before. 2 of them did it before they even graduated. And
Wow, I
and
love that.
I give them a break. I give new students a break. It's like $1,800 if they want to come, and I want them to get excited about it. I want them, and I want them to use me as a resource. That's to mentorship. That's where I really have fun. Sometimes people go on and they'll call me and they'll just say, hey, I want you to I want you to come and see how my office operates. And I do on-site mentorships all the time for people, and that's probably my favorite thing to do.
So then what? So 101, you're going to teach. You're going to start them at just 101 is just entry level. In 2 days, we're going to teach you how to place simple implants in overly abundant bone, probably lower mandibles to
Yep.
help snap on a denture. And would that be 2 implants with ball and locators, or would that be like 2 or 3 implants with a hater bar, dolder bar? Uh, um,
It's just easier to make it easy. 2 implants, locator abutments on top, convert their existing denture to get these people into some teeth, or if you're already in the process of making them a new one, then do that. But you can get as elaborate as you want. But the fact is Mrs. Smith's been in a denture for 30 years, and now she can't. She can't even hardly eat, and she doesn't even want to go to church anymore because her teeth flop around. As simple as 2 implants and a couple locators, and Mrs. Jones is bringing you a ham at Thanksgiving, and dropping you off cookies at Christmas, and you're making a difference in somebody's life.
and see, here's how you and I are like, because dentists take 8 years of college in physics and trig, and they can't even tell me what price elasticity means, and it means that price has a very elastic effect on demand. If you price it at a Mercedes Benz 100,000, you're going to sell a hell of a lot less than the number one selling car in the world, which would be like a Ford Taurus, or a lower price $10,000 car. Obviously the planet's going to buy $10,000 cars for a $30,000 car. And when you send your patient, Mrs. Jones, the older lady, had a dentist for 30 years, an oral surgeon, they only have one treatment plan. 6 implants on the lower, 6 implants on the upper, 2 sinus left. And no matter what they say, it always comes to $50,000. And then you say the oral surgeons, okay, America's got 330 million people. Why is every one of your treatment plans a Mercedes-Benz? The periodontists do it. The orthodontists do it. The orthodontist never going to say, well, Justin, we have 2 things. We have a low cost 6 months braces. We're just going to kind of level the line everything for 6 months. And we got a high cost, a 2-year, 24, 30. It's always one high price. This is why I like general dentists like you and me getting in this. You're taking her existing denture. You're just putting in 2. Look, you're just down dirty. I mean, you're the Henry Ford. Make it for the masses. You'll make so much money. You'll be rich and eat with the classes. But when you only aim at the classes, you'll be broke and you'll be living with the masses. Why do we see price elasticity? Why do we see that in cars? There's a Chevy and a Pontiac and a Olds and a Buick and a Cadillac, whereas the oral surgeons and periodontists and orthodontists only see the Cadillac.
Yeah, I don't know. I think this is why I enjoy your friendship too, because like yourself, it doesn't bother me to upset somebody or to make somebody think about what they're doing themselves. Up here when I first moved to Rapid City, I was I was looked down upon as far as in the specialty world and those that were already placing implants, because they were too darn high. And there was no reason to be, so I came to town with a $1,600 fixture, and I only have, if you come in and you have an edentulous mandible, you can spend 2 hours talking to that patient about 1,000 different treatment plans, or you can do what Zig Ziglar's always said, and that is, if you show them more than 3 options, they're going to choose none of them. So for me, my lower treatment, I'll share my, if it's a pearl, whatever, but it's how I treatment plan everybody with an edentulous mandible, is your options are having 2 implants on the floor. It's like a 2-legged chair. If you've been standing in line for a concert ticket, I'd take a 2-legged chair over a 4. It's sitting on your gums and it's going to rock a little bit, but you can get rid of the fixident and you can have some confidence back. We could go to 4 implants and still a locator denture. It'll snap in and on, but now we're starting to get that 4-legged chair that's still sitting on the gums, but it's starting to get more implant borne than it is tissue borne. And then if you have the bone for posterior implants, we could gravitate towards something that's fixed. And for me, it's $6,000 for implants and 2 implants and a lower denture, $10,000 for 2 implants and a 4 implants and a lower denture, and it's $19,500 for full fixed. And
full fixed, one arch or full fixed upper lower?
One arch.
One arch. Okay.
One arch.
So say this prices again. So 2 implants and
2
a
implants,
denture.
locator, and the denture is $6,000.
$6,000, and then what was next? 4 implants.
4 is 10.
4 is 10.
And then 4 to 6 implants and full fixed is $19,500. And I don't care. And I don't care if
and that's gonna be 6 implants, or you don't even care.
I don't care. 4 or 6, depending upon how many. Me putting 2. If they've got the bone for me to put 6 in, why would I charge them another $3,000 for 2 implants that cost me, $170 a piece? It took me no more time to place, and I can over-engineer this thing so that I have it last a long time. That's where I just find people that gouge them to death.
Okay, so when they come back to, you said you have 6 courses. Are they 101, 201, 301, 401?
Yep.
501? Okay,
Yep.
So what was 201 covering?
That's the edentulous maxilla. Because the maxilla is treated completely different than the mandible. So,
am I 28 years? Tell me if you agree with this, or am I wrong? It seems like when they come in, the problem's always the lower. It's never the upper. And then you fix the lower. Soon as you fix the lower, now the upper's the problem, because 100%. Now what is that? Do you see that true?
Every day.
And why is that? Explain that to these young kids why that is.
Well, the upper denture is only moderately better than the lower denture because of the suction factor, like water between two dinner plates. So when the bottom one, the tongue's throwing it around and the skinny ridge, and it won't stay put, all they're concerned about is, getting that lower fixed. But when you solidify that bottom, they don't realize that they were having the same problem with the upper. It was just tolerable.
But
So
but but is there also the other factor that they used to be chewing on that against that upper with a floppy lower, and now they're chewing against that lower with a firm fixed, far more pound per square inch bite, so that way you
absolutely.
don't
I mean,
knocking it around.
the only thing it's doing is now it's heightened their awareness of how crappy their upper denture actually was.
And just to be clear, when you do two implants versus four, those four implants are all still in front of the metal framing, correct?
Yeah, I mean, if I can put them behind the foramen, that's better. Increase your AP spread, hold the bone. But the reality is when an edentulous mandible walks in your door, you can almost assume it doesn't have any bone behind the foramen. I mean, that's just the way it is.
Okay, so what's 301?
Let's see. 301 is. I gotta look real quick. I just want to make sure that we talk about um, uh, the same things. But we've got 301 is hard and soft tissue regeneration. So we talk about grafting, we talk about sinuses, we talk about ridge augmentations, we talk about using alloderm, we talk about using free gingival grafts, things of that nature, trying to rebuild sites that were not necessarily good to begin with.
Justin, can you be can you be placing what do you okay, so we both agree probably 9 out of 10 dentists listening to this podcast have never placed an implant. What would you what would you consider the number of implants being placed a month for someone who's doing enough of them to start getting traction and getting good? I mean, I don't believe you can get good at endo doing one root canal a month.
Oh no,
I
you need to be doing a couple a week.
yeah,
Yeah,
so
you need to be. Yeah, I think if you're not placing, in that 70 to 90 implant range, you're not getting enough experience in there to see enough different circumstances to make you, good at that.
70 to 90 a month, 70 to 90 a year, you mean?
Yeah,
Okay,
yeah,
so 75 to 100 a year.
yeah. I mean,
And
that's higher than the national. That's higher than the average for sure. It'd be nice.
and another thing that I love about implants is the fact that if I build this bottle of water and I sell it for $1 and all I make profit is the cap 10 cents on the dollar, and then I refuse to spend 5% on marketing advertising, but they send me a PPO plan that just lowers all my fees 30%. Now I'm doing this for almost at a loss. And what I like about implants also is there's no fee schedule with Delta, Blue Cross, Blue Shield, Aetna, and other stuff. And so when you price an implant, it's a lot more profit dollars. And when I look at implant guys, and when I look at the total profit from the practice, implants might only be 10 or 15% of their revenue, but it's usually like half their net income profit. Do you agree or disagree with that?
Oh, I agree with that wholeheartedly. And even even in a world where you're not in that insurance, in the insurance, the it's the revenue per hour. We're in the business of selling time.
Exactly.
We've only got so many minutes in the day to do dentistry. So how do you become more profitable? Well, you need to become more efficient. And how do you become more efficient? Well, you do something more. That goes back to how I'm successful up here. You know, Everyone else is in that $2,000 to $2,500 range for placing their implants. And I do them at $1,600, and they're just like, well, I mean, that guy's just a loss leader, this and that. But it's not, because they don't understand that I've done so many of them that what they block half an hour or an hour for is a 10 to 15-minute block in my schedule. And my technology has made me so efficient, and my volume has taken my unit costs down, that chances are that my $1,600 implant, I'm crazy more successful, profitable than that person with the $2,000 implant. So when you look at implants and you place an implant in in that hour time frame, you're looking at, for me, you're looking at $1,600 of production. How many fillings can the average young doc do in that 1 hour? I mean, a couple. I mean, now they were used to doing two in an entire day in dental school. So that difference in time, in money per time, is off the chart. Um, it's absolutely off the chart.
So what are you going to teach them in 401?
We're going to teach them about complications, and this is my favorite. This is my favorite lecture. Nobody likes to talk about it. Nobody from the podium likes to show their stuff.
My first idol in implantology was exactly that. You remember? And I'm so sick, I forgot his name. Brain fart, 53. He was a prosthodontist. He ended up working for a Green Laboratory before he died. He was a prosthodontist, guest lecturer, but he would everybody would do implant lectures, and they just show all their best cases. And he had so much self-esteem, he'd go out there and he'd only lecture on everything he ever did that failed. What was his name? His last job was the dental director at Green Laboratory in Arkansas. Gosh.
I don't know that part of the history. If you say,
oh my gosh! But anyway, just legendary, and that just speaks volumes. Because you learn more in what goes wrong. You never learn anything if you do some dentistry like you always do and it always works. You don't learn anything. It's when it fails you start scratching your head, saying, "But that's the way I always do it."
I learn more. I take a post-operative CT almost every patient because it's my instant gratification on what I just did, or what can I do to get better, because I want to see how it went. But my complications. We did a lecture in Dallas this summer. There were 79 docs at the course, and it's my funnest one because for 2 straight days I show them failures. I show them there's pre-surgical failures when I picked the wrong kind of unhealthy person. There's surgical failures where I didn't we didn't even get to place the implant. There's non-integration. There's prosthetic failures. There's home care failures. There's peri-implantitis failures. All those, and every slide I show is something of my own. After 10,000 implants, I got a pile of them out there, and and if you talk to somebody and he tells you he doesn't really see that many failures or complications, I'm telling you're talking to somebody that has an ego that he can't tell you how many failures he has, or he doesn't place enough of them.
Okay, finish with 501 and 601.
501 is a full arch immediately loaded course. So you can call it all on 4, you can call it Teeth Express, whatever you want to call it. But we talk. I teach them for those that want to get into this all on 4. I teach them how to treatment plan the case digitally. I teach them how to place implants, place angled implants, use multi-units, convert dentures, and then finally choose the right final prosthetic for the solution. It's a great course for those that want to get into that realm.
And how long do you think it would take for someone to go through all your courses?
Well, it'll take a while because, if you're just taking 101 this year, you're probably not ready for a full arch course for a few years. Now the 601 is the guided implant surgery course. I love guided implants, and that's been a real topic for you lately. That's been people are pretty sold on both, either guided or non-guided across the board. And I'll throw my 2 cents out. I like to do everything guided in the aesthetic zone. I don't like to take that to chance. I want to put it exactly where the bone is and right where I treatment plan it prosthetically. The downside to guides is you can't do it every time, because as you get into the posterior places, a lot of times you can't get all your instruments and such back there. I do 42.5% of my cases immediately. Break a tooth, fix a tooth. A couple of years ago, I had an intern. You'll like these numbers. I had an intern come in, and this high school girl wanted to do something for the summertime. So I had him go back through all my CTs and my spreadsheets that I keep for my implants. And I said, I wanted him to go through, and I said, hey, I want you to go into Dentrix, and I want you to find out how important it is to strike when the iron's hot. As far as getting people to commit to treatment. And if we were able to go from the time we saw the patient to doing the surgery same day or less than 10 days out, we only had a cancellation or postponement percentage of 2%. But when we went from 10 days to 20 days, that raised to 11%. From 20 days to 30 days, it raised to 19%. And if I put the patient out more than a month, it was 29%. Would either cancel or postpone their treatment. So I'm here to tell you that, you've already said it before. People find something else to do with their money. If you've sold them on the value of what you want to do right now, I try to tell my students, that I ask them, I get this a lot, and it's not necessarily from the young docs, from the older one. They're like, Dr. Moody, I don't know about your practice, but mine's so busy, I'm booked out 4 or 5 weeks. I can't possibly move. I can't possibly do an implant in 2 or 3 days or the same day like you're talking about. My schedule doesn't. I said, Doc, I understand busy, and I appreciate how busy you are. Sounds like you may need an associate, but if that's not what you want to do, I said, is there any time in the next 10 days that you're going to do some fillings on someone? And he's like, well, I do fillings every day. And I said, then you know what I would suggest you do? I would suggest you either take that patient that you got $200 worth of fillings on and move them to your lunch hour, move them to the next day, and free up that spot for a $1,600 case. Nobody's that busy. And I'm sure I angered a bunch of people driving to work today saying, I am that busy. I can't do that. Well, if you want to, you can do that.
Well,
I'm here to tell you.
When they're booked out 4 weeks in advance, they're busy and they're batshit crazy because they cannot tell you their activity-based costing. When they walk out of the room, they said they spent 1 hour doing 2 MOD composites, and I go in there and say, how much did these cost? They're not sure because they apply to 10 different insurance plans. And they'll say, oh, they're about $250 a piece. And I'm like, really? Well, this was United Concordia, and you signed this PPO, and no, they're not $250 a piece. They were $180 a piece, and you just did this much revenue. What is your cost in this place per hour? I don't know. How do you even know you made money on that? I don't know. So you're booked up a month in advance. So when I'm the customer and I say, gosh, can I get in? I broke my tooth. I want you to help me. You're so busy doing dentistry with Stevie Wonder, Ray Charles accounting, where you don't even know if you're making money, losing money, whatever. I mean, it's just, I don't know, not having the practice management software hooked up to Quicken or QuickBooks Pro, and nobody knows their activity-based costing. And what I see is the guys like you and me who know we got procedures without doing the math. We know you're heavily in the profit zone. I mean, look at the endodontists. They average a 40% overhead across the country. Oral surgeons are 40 to 50. So when you're doing a molar endo, you don't have to know your fee. You're in the profit zone. When you're doing extractions and implants, you're making a ton of money. But I would challenge almost all dentists to tell me they make money off cleaning, exams, x-rays, and fillings. Show me the math. Show me the math. You're telling me something because you got a gut feeling and your guts are filled with shit. You don't even know the answer. You have a shitty opinion. You're making money. And then you're the first one to tell. And then when your accountant calls you up in April and say, oh, Justin, I'm going to need you to write a check to the IRS for 40 grand. You're like, 40 grand? I don't even have $40. I don't have any money. Right. I've been busy all year and I don't have money to pay my taxes. And then that's the same person who doesn't want to learn how to place implants, do molar endo, do Invisalign, do anything where you're sure you're in the profit zone, and they just want to do fillings all day long.
I asked the class 2 weeks ago, how many people in here know, what their what their net margin is on an hourly basis. And they're just like, they just looked at me like that. And I said, it's two things. What do you want to make per hour? But what are you actually netting per hour? Because that's a real number that every practice should know, but nobody does it. I would challenge you this. You want to make a difference in my world? You want a difference in my world? You need to call Dentrix up and tell them how to figure out how to link that into my QuickBooks Enterprise so that I can actually have a real-time accounting of what the hell is going on instead of having to look at a dual monitor deal.
So I love Stan Bergman of the CEO of Shine. I
Absolutely.
mean, he's a great guy, and he put this MBA on it from Shine, and they surveyed a bunch of dentists, and they asked them, "Do you want that?" And they actually said no. They wanted voice activated perio, or to be able to change the font of the chart, or turn the text from black to fuchsia or yellow or green. I mean, and that goes back to Henry Ford. Henry Ford said you, and Steve Jobs, both of them said your customers don't know what they want till you build it for them and show them how to use it. And Henry Ford, if he, when he started, everybody loved their horse. If he would have said, "Hey, you want a horseless carriage? Hey, Justin, you can shoot your horse, stop feeding it hay, and buy my horseless carriage." Well, I mean, everyone's in love with their horse. He knew a horseless carriage was better than a horse and buggy, but he wasn't going to touch the horse. He's going to build it faster, easier, lower cost, and put it out in front of him and say, "Yeah, but can your horse go 60 miles in a day? Pretty sure your horse can only go 20. This baby can go 100 in a day." And
Yeah.
and same thing with Steve Jobs. I mean, every product he came out with was innovation. These dentists got to innovate, and they got to innovate. They got to help patients, and they need to stay in the profit zone. I like to make decisions. I think a lot of dentists get frozen, Justin, because they don't know what to do. And if they have two choices, just like a patient, offer them three choices, they'll pick none. Tell them what to do, they'll probably do it. And I'm telling you, if you listen to this guy, I know Justin. He's a good homie doing it in real world. Go to justinmoodydds.com, and he's going to teach you how to do implants. Number two, Justin, there's 275 implant companies. Should these guys go from agnostic to actually buying a kit? And if they were going to buy an implant or pick a brand with 275 brands out there, what should they get and why?
Well, listen, it's no
I
secret.
mean, how many kits have you worked with
Uh,
in your life?
half a dozen.
Yeah.
Zimmer, Sterngold, Corvent. I even started back when Corvent was still around. Nobel.
Was that Jerry Nesnick's company?
Yeah, Nobel.
Which was brand
Camlog, and now but since 2006, I've been with BioHorizons, and they all work. Don't get me wrong. They all work. So if they all work, how do you choose one? Well, I like to choose one that A, has good customer support. I do like I choose BioHorizons for a number of reasons. Not necessarily price. Because they're not the high, they're not the low, but they were put together by a bunch of good old engineers in Birmingham, Alabama. This stuff is American made by American Auburn and Alabama graduates. These guys, if you ever get a chance to go to their corporate, these guys are the real deal, and I couldn't imagine going anywhere else.
And they were linked initially with Carl Misch, weren't they?
Well, Carl helped him with some implant design, initially the square threads and some things with some people like Martha Diaz and some others. But today BioHorizons is run by its CEO Steve Bogan, who's just one of the best CEOs on the planet.
I agree, he's a great guy.
And I'll tell you what else they have is they've got the only surface treating that the FDA allows them to say that they have soft tissue attachment to the implant. It has this surface treatment called laser lock.
Okay, I want to ask you. Go ahead. Finish your deal on laser.
Well, you talk about bone loss and so forth. Wouldn't it be? Everybody talks about the bone to implant junction and how we can minimize bone loss. Think about taking a platform shifted implant, putting this laser lock on it. So if there's any portion of this implant that is exposed, soft tissue will grow to it. Even putting this laser lock technology on the underside of your abutment, which is actually giving you a seal from the microgap itself. I mean, when I went from Zimmer to Bio, I saw less bone loss. But when I went from their tapered to their platform shifted implant, bone loss is a thing of the past. So why I choose BioHorizons is the science, on top of the titanium.
Okay, how would you have answered this question? I got this asked during the Cardinals game last week. One of the woman dentists at the bar, young girl, I think out of school 4 years. She goes, well, it doesn't make sense. I mean, she lost this tooth from gum disease. So now you're telling me to put an implant in her mouth that she lost from gum disease. The bugs are still there. She's just going to get peri-implantitis, and it's not going to work anyway. What would you say to her? How would you have answered that? I mean, if you lose the teeth from caries, she gets it. I mean, you're not going to get a cavity
For
on a
sure.
titanium implant.
For
But
sure.
when you're losing your teeth from P. gingivalis from gum disease, and then you're putting implants in there, is this a setup for a periimplantitis?
Well, it certainly doesn't help you in my, as I've gone through over the years, one of my risk factors that I identify in my patients is, uncontrolled periodontal disease. And um, that's a hostile environment in itself. The mouth that when that periodontal disease is hostile and it's there, you're going to open up yourself to more periimplantitis. Those are the patients. If it's system wide, those are patients that you should really think about getting rid of the disease. Get rid of the disease first. Come back when the bug is out. Because once you remove those teeth, the bug's gone. The periodontal disease is gone. So, come back, remove the teeth, do some grafting, put them in a set of immediates. I like immediates because it lets them appreciate what you're going to do and you're going to
Exactly.
spend on the implants. That's the only downside to the immediately loaded case is that the patient never has to experience what the rest of the world, the rest of the edentulous world has, and that is ill-fitting dentures.
So when someone's got a full mouth of gum disease and you pull all their teeth and you put them in implants, I agree, because when you pull all their teeth, it's like a baby. A mother can't transmit P. gingivalis to its baby when it's
No.
edentulous because it has no anaerobic place to grow. It's only when the tooth pops through is that little tissue over there where an anaerobic streptococcus mutans or P. gingivalis can grow. So when you pull all those teeth, there's no place for the anaerobic bacteria to live now in the mouth. And then you put them in immediate. How long do you think they got to be in immediate before you go back in there and start putting implants in, and you think they're less susceptible to periimplantitis and P. gingivalis?
My personal experience is 4 to 6 months. I don't have
Okay, okay,
I don't have a literature article to cite on that, but of the hundreds of arches I do a year, the best long-term full arch success I have is when I get rid of the periodontal disease teeth, come back 4 to 6 months later into some nice bony spots, put my implants where they need to go instead of maybe where I was trying to pick and choose between extraction sites and such. They just do so much better.
Justin, we are out of time. It's been an hour. You're my idol. You're a rock star. Everybody I know that knows you, seriously, worships you. You're just a good old guy, good old boy. And I'm really, I'm going to say this because I've been begging you for a long time. You got 6 classes, which nobody listening to this is going to go take that class and then send me an email that says that wasn't worth my money. I mean, you just couldn't do. This guy knows more than you'll know in a decade if you just did it full time. And number 2, I want you to put a teaser hour of each one of the. You got these 2-day courses, and instead of them just a flyer with some print, I wish you would do an hour course on each one of these 6 deals so they can get to know you, so they can hear you. So it makes it psychologically easier for them to say, I like this guy. He is smart. I do learn a lot. And you can't learn how to place implants at your dining room table. You actually need to go see some and go to it. Any chance we get those?
We're working on it, sir.
You've been saying you yeah, okay. I hope so. Well, maybe this podcast will hold your feet to the fire. But thanks for training so many dentists. You were in town last week. Everybody that every dentist I know that's ever heard you lecture or whatever just thinks you're just down to earth. You're approachable. You're wickedly smart. You're very successful. Thank you so much, Justin, for spending an hour with me today.
Appreciate your time. Thanks, Howard.
All righty. Have a great day.
Yeah, you too.